Right, shall we get started, everybody? Slightly late, just checking out who's online. See, Steve's online. Welcome. So, welcome to the Trust Board in public. We're going to start with apologies for absence and declarations of interest. Laura.
We have apologies from Bernie, Paul, Phil and Veronica, and Margaret will be joining us a little bit later.
Okay, brilliant. No declarations of interest. We've got the minutes of the last meeting of the 23rd of May. Are they all accepted? Does anybody have any comments? Excellent. It's going well. Sorry, I should have pointed out that I'm chairing as Paul is conflicted today because he's at Newcastle, isn't he? So I have you this morning. Action log and matters arising. Action log, health inequalities in our board development programme, I've seen that, and then completed actions we've got this to go with. Any other comments on the action log? No? Right, Bijou, you're on.
Thank you, Ruth. So, just a quick in terms of the dashboard, and whilst we still see a number of reds there, progress this month of June has been really positive. So, the incremental steps in terms of delivery of our performance, improvement in our performance is starting to show. So, these are provisional figures for some of these, particularly around the delivery of the 18-week standard and our faster diagnosis, sorry, 62-day cancer standard. Both of those, so RTT is ticked to 81%, and the cancer standard is likely, once the shared breaches have gone in, to tip into 80% as well. And whilst that doesn't meet the constitutional standards yet, it is progress on where we've been from the start of the financial year. Strong performance from a money point of view still, and we did have some public perception results that were available to us just pre-election, but for obvious reasons we weren't able to share those at the time, that despite where nationally people feel about the NHS, locally we're still seeing in a very positive light, and that is very reassuring. Plus, we have our AGM later on today, which will, it's the AGM, it isn't the AGM, because we can't, for purposes of laying our accounts before Parliament, haven't happened yet. But we'll use that as a celebration event, particularly looking back over the past year in terms of a number of things that as an organisation we've been able to deliver. So that should hopefully be a very positive and uplifting event later today. Happy to take any questions.
Any questions of each? No, I think the figures are, we see red and it's terrible, but in the world of the NHS it's still very, very good performance, isn't it? So we don't need to know that. We've then got Chair and CEO's engagement update.
So people would have seen the report, or had the opportunity to read the report. And this is now, we can report this one slightly earlier just to get us back into sync. A report that myself and Paul update the board on in terms of engagement activities that we have undertaken. So you've got for Paul, if that's okay. You'll see that Paul's update there in terms of governor activity, governor meetings, and some of the elements that have been picked up and acted on as a consequence of there. And you will have also seen, from my point of view, the engagement that we have, both in terms of alliance activities, but also the provider collaborative and with ICB colleagues. We've also had, very recently, just the past couple of days, a visit from Bath University Hospitals, whereby we were showcasing some of the work that we've done here, and there's a reciprocal visit around their maternity services, which we rate as outstanding, probably one of the only ones in the country, to see if there's anything more we can learn from them. And then we're also looking to send a number of people down to Maidstone and Tunbridge Wells. Again, it will end up being a reciprocal visit, but more around learning for us and vice versa. So they are an organisation that probably tracks us quite closely in terms of performance and innovation as well. So there'll be some cross-learning there. for us. We also had in June our first due diligence clinical policy group, so that's where clinical leaders from across the organisation came together very much to test our new clinical front door model that we're proposing to implement from September. There was a subsequent one this month as well, so that was seen as a positive event in terms of the energy in the room, but also the mutual respect in terms of challenge that took place between clinical teams to make sure that our new model was robust.
I was remiss because I didn't say this is our first meeting in this fabulous new building, didn't I? So even though I'm a little bit warm at the moment, it's great to be in this new facility and see that we've had our first cohort start, and that's really good news. It's just a positive for us in terms of progress, isn't it?
Absolutely.
So, sorry, I should have noted that at the start. Right, Andrew, I've got you on for the Alliance update. Yes.
Do I need to press the button?
No, we're on ceiling mics.
Right, fine, sorry. Great, thanks all. There's a paper, just the first thing to say, this update is going to all the 4 boards across the Alliance in parallel. There was not really an issue, but a kind of quirk of pre-general election timing, and actually some of the previous update wasn't heard in some of the other trusts. I think there's a quick update to the May board. So there's a bit of repetition to allow colleagues across the Alliance to catch up. Essentially, the paper sets out the update of where we've got to, what the focus of the work is. A few things to pull out of that. So clinical colleagues have fed in some really helpful input, and we've sort of restructured the different themes that we've been working to. So they're set out in the paper, but clinical projects and pathways is obviously a really big area of focus. There's also professional issues and opportunities, some of which will of course be for clinical colleagues, but others would be, for finance professionals, HR, digital, etc. And then there's some more cultural and enabling work, and actually those 3 themes have resonated really well, I think, not just within colleagues working on the Alliance, but also beyond that as well, boards and the organisations that they represent. A quite significant milestone, I think, since the previous public board update has been the first instance of the committee in common for the Alliance. So each trust's board has a committee set up which then meets all together. There was a collaboration agreement agreed to underpin all of that, and we have the same terms of reference, and that really just helps to formalise the governance on all the Alliance work and what the progress is going to be. Looking forward over the next few months, so we will continue at pace to work with colleagues in the different organisations to take forward the individual work streams which are referenced in the paper. We've had some positive engagement and support from colleagues outside the Alliance, including a very successful meeting with the ICB a month or so ago, and they're very supportive of what we're intending to do and want to support us in order to make sure that it is a success. And we're looking to come back in the autumn with a more substantive and detailed update to both private and public boards.
Any questions or comments for Andrew? Claire.
So it's really a question, Andrew, because we had the lovely meeting. There's been a few actions that we've undertaken, and collectively the medical directors have all helped and supported you. It's just really, from your perspective as organising the Alliance, is there any more that we can do to make sure that you're supported in your programme keeps developing? It has been, it can sometimes be a little bit different in everyone busy working.
Absolutely, and I think especially that's probably been the case in the earlier establishment phase. I think it is increasingly for the individual work streams, it is becoming more within business as usual, and it's changing how people are working, and that we are naturally including colleagues from the other organisations in conversations about whatever the particular topic might be. So I think we feel that change happening. It's not equal across the work streams, but it doesn't necessarily need to be. I think, conscious that everybody has quite a lot on, and I think where colleagues around the room and in the other organisations feel like there is potential and there is more support that they might need to actually take forward an individual action or a particular work stream. We'd like to know about it, and there is that honesty and trust across the Alliance for us to have those conversations.
I think just to, on that point, there is also quite a lot of bi-directional work being undertaken, so we're just going through a process whereby we want to make sure, as well as the Alliance by 4 work streams, that we're aware of all the bi-directional stuff that's going on across each set of organisations. So, for example, between ourselves and Newcastle, or Newcastle and Conwy, so even though we're not involved, this just builds on some of the trust and respect and transparency, so that nobody feels like there hasn't been something that they're aware of or not aware of. So that's just, we're just going through and collating that for all of the organisations so we can clear.
Yep. Steve?
Thank you. This was just probably, I suppose, a bit of an update, but also maybe just sounding out on things that are happening anyway.
We can't hear you very well, Steve. You might need to shout up, I'm afraid.
Oh, sorry. So this is largely about health inequalities, but also charity and potentially a bit of say as well. There was already a piece of work going on between us and neighbouring trusts in terms of the NHS charities. It was just a flag that that's still happening, and we're happy just to progress that in a business as usual sort of way. But I guess I'm just logging that with you just for your conversations that Gateshead and Newcastle are amongst that group, and we have considered whether or not to limit our sort of regional ambitions to just focus on those trusts who might be part of the Alliance, to work on a piece of joint work around health inequalities. At the last Charity Strategic Committee, we had a good presentation on transport and the problems of access for people, and that may be a focus for some work that we try to pool our resources going forward. But obviously, because of these conversations now coming in, after that, we just want to make sure that we're doing things in the right way to make sure everybody's sighted on various matters. In terms of the charity particularly, we just worked on the assumption that there will be no such thing as a Great Northern Healthcare Alliance NHS charity will be stronger in terms of how we connect with people, raise funds, and spend funds by keeping distinct identities. That's never been on the table, but there is this collaborative approach to working together that we're talking about, largely around the health inequalities. I just wanted to flag that up, Andrew, in case you have those kind of conversations or recalls in the forums.
That's really helpful. That's really helpful, Steve, because we, as we say, we're collating some of this just to make sure that we're not missing anything. That's to not, we don't want to hinder progress that you're clearly making in both of those, both in terms of the charity and the inequalities, and would encourage you just to keep that going, but at least it's logged so that when we are writing up the activities that are being undertaken across the board, that can be mentioned and not missed off.
If I can just add to that as well, Steve, if it's helpful for someone working as kind of more closely with the Alliance or the Alliance formation team, for instance, such as myself or one of my colleagues, if it's helpful for us to join some of those conversations and give an overview of the other work that's happening, obviously just shout and we'll be happy to do that.
Okay, thanks, Andrew.
All right.
So I think that's a good point point, Andrew, and I would really like to come to the boards, particularly surgical board, because we've got a lot on with that.
I think the thing to keep in our minds that we talked about at the start of this alliance conversation was we need to remember that this is about patients, and we need to keep our focus on, Andrew, and I'm not suggesting we're not, but I just want us to keep our focus on, let's see where the benefits to patients come out of these things. And Steve's point about health inequalities is a really good one, because that's a positive, absolutely positive push. So I think in everything that we do, I know we get tied up in reporting lots of things, but I think if we keep the patient focused, that would be really, really helpful. Okay, excellent. Anybody else got anything they want to add, or are we moving on to Chris? Right, Chris, over to you.
Thank you. So the next item is a report on the back of an NHS England letter we received about maintaining focus and oversight on quality care and experiencing pressurised services. So this letter came on the back of a Channel 4 Dispatches documentary that was shown in the ED at Royal Shrewsbury Hospital. And the documentary, if you've seen it, does highlight and portray sort of quite poor care that patients in that services experienced. And a lot of that's brought around by the pressure in terms of when the patients coming in and the flow of the department. So NHS England wrote to all providers requesting that boards assure themselves that we're working both internally with system partners to make sure that our patients that we serve aren't experiencing similar issues. So there's a number of areas of assurance and actions that we needed to go through. The first one being that the Trust is working towards the UEC recovery plan. There's three elements to that. First, about maintaining capacity to deliver required activity. So I think we've got a number of actions in that area, things like increasing the bed capacity in the autumn, the ambulance handover process redesign, which has had good benefits, and looking at our offering in terms of SDEC and alternatives to ED, to keep ED just for ED patients. Which brings on to the second part there about productivity and changes that has been described to the board before in terms of the plan to redesign that front door then set to again protect ED, focus ED patients and get other patients to areas more appropriate for their care. And some of those areas around within the hospital settings, so things like virtual wards, to our community urgent response area. So I think we've got a lot of good work going on in the area on that recovery plan. The second area we need to assure ourselves, or need to assure ourselves around is about the basic standards of care. So I've listed there on the presentation there a number of ways that I think that we can provide that assurance. I think we picked up on Monday the importance around that 15 steps and that first impression of a ward, and you get that feel for a ward and environment in an area. So I think they're really important to carry on and keep them doing. The third area is around working with system partners, including our local authority partners. And I think the conversation on Monday was around that we're always going to have delayed transfers of care within our system, within our hospital. I think the thing to mention on that is that relative to other areas and other providers, that's at a relatively low level, albeit higher than any of us would want to see. I think it's something about the positive relationships we have with local authority partners that we can have those positive conversations about an individual patient on more systemic issues and working in a really collaborative way. So moving on, the next bit was around 7-day hospital service audit. And we noted that we did this regularly up until basically COVID and NHS England requirements and that reporting changed. However, we have done a snapshot in April 2024 on elements of the 7-day service. So around the elements of the time to get consultative review and then ongoing review of consultant care, and we're just finalising that audit at the minute. The results look in line with what we had pre-2019 or in 2019, but we can certainly share that around the board once we have those finalised. And then the last two areas where we needed to provide some evidence of was around kind of visibility of the emergency care pathways and visibility into other areas of the trust to ensure that care, the care we want to see our patients receive is being received. I think from an senior management perspective, there's a lot of, I think, kind of pride ourselves on the fact that we're visible and then we're in departments and we're in areas and we can kind of see things as they're happening. And we also have the non-executive board walk around, which we've got the formal agenda later on. So I think they give a good oversight and a good feel for what is happening now in our hospitals. So in summary, I think there's also something about the context that we're dealing with at the minute in terms of that demand for non-elective services, both from self-presented patients and by ambulance conveyances. But I think even with that context of that increase in demand and increase in pressure and inverted commas, I think you can see from the assurances we have in place, from the way we monitor and measure it, I think you can really see that the care and the treatment that our patients receive is of a good high quality. And there's nothing that sort of stands out, kind of think out into the hospital areas or any processes where I think we really need to be concerned about. That said, I think we do need to keep regular reviewing this, and we agree that we bring that back to the on a quarterly basis, which we will do. Any questions?
Any questions or comments for Chris? Jeremy?
So if I just may take the opportunity at Public Board just to really comment upon how the system overall is responding to some of the pressures which I think we feel day to day. There are a number of individual cases that come across my desk, and we are in a very tricky position as a health population. We have enormously high expectations and a reduced appetite for risk. And that is inducing us into certain behaviours that actually are imperiling the staff and the areas in which they work. And that's, I think, one of the fundamental issues to which it is very, very difficult unless we work collectively on those things to sort those out, because more and more questions are being asked of essentially a single location. And whilst there has been an important performance focus within those areas, it is only by making other parts of the system recognise the risks that are going on in the So I have enormous respect for the work that is done in our emergency departments, and it really continues to be. I think I've been through the summer. Astonishing rates of attendance and the particular amounts of work that they're being asked to process.
Understood and agreed.
Just to add as well that we recognise the impact that none of us are comfortable at all in terms of when we have patients on corridors, which we do have at times of immense pressure, and we also will recognise how much that is not good for our patients, but also for our staff as well, and the impact that has on them. We'll hear later on from Joe the work that the patient and staff experience that's generating that allows us to try and help mitigate some of that. So this is an issue for both our patients and our staff, and we need to try and find a way whereby we can manage, as Jeremy's alluded to, some of that huge demand that's coming in through our doors at the moment, which is some of the clinical strategy changes, but that won't fix everything. Some of this is an ongoing conversation we're going to have to have.
Absolutely. Margaret, you've got a question?
Yes, please. I've just followed on from what Jeremy said, and I absolutely agree with him. And I think, we need to really ensure that we are thanking our colleagues at ED, that they're working incredibly hard. I just wondered about the pressurisation, and we've seen it nationally, but within Newcastle, are we seeing the same sort of increases there? And Jeremy might be able to answer it or not, or BSU might be, but it'd be just interesting to look at a comparison.
So the actual volume levels we are somewhat different in terms of overall volume of activity coming in through our emergency department. I think it's us across the region, I think it's ourselves and County Durham and Darlington that have actually seen the stepped increase year on year. And we particularly, you'll know this, Margaret, that it only takes 1 or 2 days of real spikes in activity that can knock everything else out of kilter. I think, unfortunately, when we talk about corridor care, which is what this report particularly alludes to, I think it would be fair to say that we see that across the whole region and probably nationally. And that's probably a state of where we're at. I think where we need to try and assure ourselves is that it happens at a minimum level rather than it just being an everyday occurrence that people walk past. And I think we can feel comforted by the fact that when that does happen, we see the reports 3 or 4 times a day in terms of how many patients are in the corridors, if that happens to be the case. And it's the first step of that de-escalation is to get people off corridors.
Absolutely. And it doesn't look like it's the time. It doesn't look like the tide will turn on people turning up, does it? So we really are going to have to just keep this going all the time.
Yeah.
It's a very difficult and challenging environment. I think the board, we do acknowledge it, and as Jodie pointed out and Margaret pointed out, we are very grateful to our staff for the way they respond to it. And we are not in the position that's being seen in these awful documentaries and shows that are disclosing it, but it is not where we want to be, is it? That's the 11 o'clock test.
And I think as well, just to assure ourselves, we obviously have a lot of people on who are on the senior managers who are on the on-call rota, and those of us that are no longer on the on-call rota, our presence is there. And the directors do the drop-ins, but I think some of us who don't do that on-call rota anymore are still always present at various times of the day as well, because there's no point just always turning up at lunch times, that early morning, that late night, that weekend visits, and the staff really appreciate that as well.
Alistair?
I think particularly in the context of public order, it's important that we kind of look at demand for healthcare as not necessarily a bad thing. If people have got needs, that we need to meet them, but I think there are 3 bits within that. One is how we take the public about proactively helping their own health, because I think we've seen that the public have got less healthy over the last few years, and that's local and national discussions. The second is meeting that demand, but the third is what's mitigable, what can healthcare do, and there are lots of issues that actually aren't cured by doctors and nurses, and it's actually what can be corrected or cured or treated and what can't, and actually be much more overt with our public, because I think at the moment some of the demand is in hope rather than actually in reality of care, or we can do a lot for somebody with complex frail elderly, and actually it's not going to materially improve their quality of life. And I think we need to be really clear with our public and take them on that journey about how can we improve their quality of life, and doing things to people which doesn't improve their quality of life is not necessarily in their best interests. And so it's a balanced argument, but I think it's really important that we always bear that in mind rather than just focus on demand itself.
Absolutely, and now Jodie constantly uses it. Realistic medicine, and it always sticks with me that we've got to be clear and quite honest with people sometimes about what is going to be a benefit.
But I think just to respond to demand, we will not deal with those other issues, and it won't work to just respond to them.
Absolutely.
In fact, it may even be self-defeating the better we are.
Yes, build it and they will come. I suspect it's a slight risk, isn't it? Okay. Any more comments on that? Should we move on to Jo and Patrick about freedom to speak up?
Thank you, Chair. So this paper is detailing the interim arrangements for the Freedom to Speak Up Guardian for the Trust at the moment. So Patrick and I are interim Freedom to Speak Up Guardians, which we started at the beginning of June, and that is to cover the substantive post holders' absence, which we have currently. The duration of the cover is not. We don't know the actual length of that time, but it's just a rolling interim cover at the moment. So up to this point, we've done all of the requirements in terms of governance. So we've done the online training that's required. We have also registered as Freedom to Speak Up governors with the National Office, and we have our confidential email in place. We have started from day zero so that all of the cases that were brought up previously to the substantive post and the confidentiality of those are maintained. So Patrick and I are starting with our own cases, and we're managing those according to the policies and procedures. So far we have had 9 cases, so slightly different to what's in the paper because obviously the paper was written a little while ago, and all of the staff have come from admin and medical up to this point. I'd say it's really too early in terms of the number of cases that we've had to start identifying any themes at all, and we've started to attend the regular meetings, so with our heads of service, for HR managers, meeting with the police, etc.
Kit.
Thank you. So just for the board as well, this looks very different to what we would usually present at a public board, and because of the fact that we can't access the previous data just due to confidentiality, but for assurance of the board, for cases that we were aware of, we have approached as individuals to give them a route to continue to raise concerns and continue to be provided support. So I think that's been helpful for them as well. We've also had assurance from the national team that in between us putting the interim arrangements in place and the substantive posts ongoing, being absent, there's been nothing that's been raised through that route as well. So we're confident now that with Joe and Patrick, that people know that they're there and people are raising the concerns. I also want to mention to the board that yearly we do a board reflection tool for Freedom to Speak Up, and as an action of the board reflection tool was to review the model. So we've commissioned an external review to review the Speak Up model, which we'll be bringing back to private board, I think, in September. So that work's ongoing, looking at the model and how that works currently in Northumbria, looking at the region and nationally as well for different types of models.
Yeah. That was going to be my question, was how do the people who are in the process know what's happening for them?
Yeah, so we have approached them and they're agreement.
And we've got a bounce that sends them to the new system, so you're picking those up. That's good news. Anybody else got any comments or questions? Okay. Excellent, that's good. Seems to be working, that's good news. Equity, I'm going to get back to learning. Equity and inclusion report. We were told we weren't allowed to use short letters, so I'm going to
I know.
inclusion.
Yes, you can tell me off later on. I'll get my badge changed as well. I'm still a general manager in community health services. Okay, good. This is just a summary of the report. The report's actually really big and it'll go onto our website. It's currently being redesigned by Comms, who did a really brilliant job on the last one, made it really accessible. All I've included in this is really the kind of highlights that we wanted to kind of pick out. So, you know, the board have made a real clear statement of intent about what we do and what our trust is all about and kind of what our values are and how we demonstrate them. So really what the report does, and what I've done by and large, is to try and kind of make it a really balanced report with putting patients first, so that we can see kind of very clearly that what it is that we do is we take patient needs very, very seriously. We've got a good story to tell about patients and what they tell us in some of the real-time and the right-time kind of data that we get. So we tried to capture that, but the other thing that I have put in there very clearly is some of the patient and staff stories that we get from the wards directly, and not just positive ones, some of the ones that maybe where people haven't had the best experience, and particularly some of those are around things like food and noise and all the rest of it. So being able to demonstrate in that we've actually taken action based on what those patients have told us. And certainly that we communicate that really clearly to the wards through the team, so they really get some kind of timely information so that they can put some changes in place if they can. The other thing that I've included in there, of course, is all of the information and the links to things like Freedom to Speak Up, the National Staff Survey, and the other kind of pulse surveys that we do as well, and the dashboards that we present to POD and PCC, so that people can see the kind of the governance arrangements we put in place to challenge some of the activities that we do. I've also put something in there about the staff networks, and we're reviewing the staff networks at the minute, and there's going to be an additional one, which is women working together, which is very timely, I think, given some of the the kind of national reports that come out about kind of misogyny and sexism in the NHS. And that was it, really. I just wanted to do a kind of a quick whistle-stop tour of what it is that we do at the minute. Essentially, this is our public face. This is what we put on our website. Anybody who wants to join us or wants to kind of see what kind of organisation we are can have a kind of a snapshot, and it brings it to life a little bit, I think, the culture that we have here. And this demonstrates what staff tell us and their staff say.
Any questions or comments? Richard?
So I've said elsewhere, I think this is by a country mile best quality and inclusion report I've ever seen. So well done, Patrick, and all the team for putting this together. I think it's approachable and it tells the story really well. A lot of the problem with this area is it doesn't make sense if you don't have data underpinning it, and a lot of the challenge of work on equity and inclusion is getting the data right. The challenge then is that people get carried away with the data and the report is all about the data and nothing about what you're doing about it. I think this has now got the balance right. You can tell the data's there to underpin it, but it's not the story, which I think is really good.
Ross?
I'll be brief, Richard, still most of my things. I was just going to say, I think some of the stuff you see on this nationally can be really complicated and can turn off the reader a little bit. I think the team's got the balance of this, just writing the story right as well. It tells some really good stories, so just to say from our end as well, well done.
Okay. Again, I think it's a fantastic report, well done, Patrick. It is extremely complex, and we do receive a lot of information nationally and regionally about the standards with ENI. So Patrick's enabled us to get into a place where we've not got 6 or 7 action plans anymore. We've got one to provide and focus on the top areas, and we're doing that through our people inclusion committee.
So again, to support everything that people have said, I think as well though, there's a credit to the board in terms of the work they did in terms of getting a clear definition of what it was that we believed as a board equity and inclusion was about, because it allows them the report to kind of work through those 3 pillars. So I think that helps in terms of this, because our job is, isn't it, to make something that's complex, simple, because it's simple for us to understand, but also our staff and our local communities.
I think the challenge there is making sure that our staff do see that, it's communicated appropriately, and then understand it, and then it's
I mean, again, echoing what everybody said, but I think one area that we do tend to miss out on, and this is me being proud of NPC, we've been really key to getting the using digital flag out, and some of our GPs have helped write that, and it is going to change the way that we provide support for patients with barriers and impairments, and I think it's a massive change, and I think starting to echo how that's really, really good, and how trust has been central to creating that across the NHS would be really good to focus on.
We'll expect to see it next year, Katie. It's actually when it's doing things and we can start to see it and get data and be able to demonstrate it, that would be really helpful when it's supporting through.
And it's useful to get those challenges, because you do fall into a pattern of kind of doing the same.
Yeah.
We get a good story from staff and from patients, and it's easy to miss some of the nuances, isn't it, and the areas where we might kind of fall short. So,
Yeah, we are changing, trust the carers strategy, there are new things coming on board, and I think that's really positive, and we're starting to look at different areas to focus on. Jeremy?
So just really to echo all of that, and I particularly like the way you laid out the patient stories, the good and the bad. And you can just see those pressures and how difficult it is to include everybody. When we are dealing with such demand and huge numbers, and how important it is to, throughout that, focus on the experience of not just all of the patients, but also those who are disadvantaged and that will feel it the most. So I think that's great, and we're soon going to have a patient charter where we have got a real focus on this, but there will be, particularly on what you're talking about, Katie, there's going to be lots to do.
Margaret?
Sorry, I was on mute. Just following on what other colleagues have said, really good report. We did talk about, the so what when we hear negative stories, that we need to have a response to the so what. So it's good to see the feedback to the wards, particularly in relation to the food. So thank you for that.
That's a very good point. Okay, any other questions or comments? No, excellent, really good report, Patrick. And it's very understandable, isn't it? I think that's a real positive for me. You can pick it up and read it and actually not get lost in piles of data, so that's a real joy. For me anyway. Right, Guardian of Safe Working, Jeremy.
Yep.
Where's Mike?
Actually, I don't know that he's anywhere as exciting as he was last time when he was off seeing Madonna. So, but he isn't here.
I know.
And
He's got other things to do.
he's got
real jobs.
He's got other things to do, and so he has written the report for me, which I'm very happy to present on behalf. The report is essentially that we continue to have an effective system to help protect our training doctors, and that Mike continues to be a key member of that, and that in general the numbers are showing that we're continuing to make progress. I think this is going to be an area that is going to receive quite a bit of scrutiny over the next 3 months or so. I think it's going to be key to the new government's strategy in and around whether it will be contractual changes, but around the new deal that they're probably discussing with junior doctors right at this very moment. And I think we will look forward to helping support them in whatever comes up with that. It's always a tricky time of year, and we're expecting a lot of new staff into the organisation. We want to make sure we onboard them into what is a very complicated system of rotas and working arrangements as inclusively as we can. But happy to take any questions.
Any questions or comments for Jeremy? Richard?
Just one question, that was on the attendance at the postgraduate doctors forum. Although it looked really good last year, it's sort of tailed somewhat, and I know it's not been the easiest year with postgraduate doctors, but is there a need to re-energise that?
We absolutely will have a go, but even when we order pizzas, they don't always come. But that's something I really appreciate. We have a Health Education England leadership fellow who's one of the GP trainees who helps Mike with that. We're always open to new ideas, but it is something I'm afraid that does wax away. And I think the truth is that many of them feel employed by the less in the NHS rather than ourselves. We're just the people who surprise.
Excellent. Good report, well noted. Patient and staff stories, Jo.
Thank you, Chair. So just like to start by thanking the 3 people that have contributed to the stories today. So our first story is a staff story, and I think particularly for this story for patients and staff is to link back to our staff survey in some ways. So we have a number of questions where we ask staff how empowered they feel to make change and to make suggestions for improvement within their service area to improve the experience of patients. And I think this is an example where a member of staff has just been able to do that and have a go and try an idea and run a pilot. So focusing on the staff story, it comes from one of our occupational therapy heads of service who's worked with the Trust for 24 years. She had an idea about how she may provide a better service for patients with inflammatory arthritis, really trying to see how she could provide a drop-in clinic which would give her more timely access to those patients and be able to support and advise them. So she developed the idea of a drop-in clinic for those patients, which she has run a pilot. She reflects that, however, she doesn't feel that she's reached those patients specifically, but she does acknowledge that the patients that come with other forms of arthritis, who is the majority of the patients that we see, she has been able to support them and give them advice and guidance, and to give them the kind of care that she gives every day to patients, and feels really happy that she's been able to do that. But she feels that the patients who she was wishing to achieve, she hasn't been able to do that, and she will probably stop the pilot based on that. But I think it's very much showing that it's just okay to have a go, and to try and provide and improve services for our patients. I have emails are actually just to say what's next, what comes next for and what's their next stage of our pilot. I haven't heard back, but I'm really interested to know what is her learning, what's her reflections and where does she go next. 2 patient stories of people who have actually accessed the clinic, both with osteoporosis, and absolutely demonstrates what the member of staff has said, that their access to our clinic has really helped them in terms of, first of all, they both talk about the friendliness and the kindness of the staff, but also the advice and the support that they were given in terms of equipment they were able to use has helped to reduce some of the pain that they've suffered with their condition. So I think in terms of patient care and patient support, it's been a success, but in terms of the actual patient target group that the therapist was wanting to have that access to, she's reflecting that maybe it's, she needs to think about the next steps.
That's really good. Questions or comments for Joe? Chris?
Yeah. It's really interesting, isn't it? I think there's a couple of things. I think there's something about giving it a go and how do we spread that? How do we just give permission to people just idea, just do it, just see if it works. If it doesn't work, well, we haven't done anything disastrous. That's not a problem, is it? We know it doesn't work. The second thing, specific to this example, I think we should really be encouraging more. It's a double-edged sword in terms of activity and follow-up, but more of these drop-ins that you think about food being a key drive across the NHS, patient-initiated follow-ups. It's these drop-ins that you get with people when they need to be seen rather than give them a review outpatient appointment and action about arthritis and flared up, so why do I want to go and associate their names with that.
And I think one of the really important points is definitely one of the patients that may have been both of them talk about that face-to-face, having that ability to talk about it, because that is really important to sections of our patient group. It's not always a telephone consultation, face-to-face can be really important, certainly.
Yeah, I think that's my view was, try it. Yes. We've got to be good at letting our staff, giving them that independence. We talk about a lot, don't we, about saying, have a go, it might not work. And if it doesn't work, we'll learn from it, we won't do it again, we'll do something differently, because otherwise we'll never try. And I never want us to discourage the staff from having that initiative to try new things. I think that's really important. And it clearly had some benefit. There's some really good messaging on here, isn't there, about the benefits the patients have had. Now I've got Margaret and Steve with a question. I didn't see whose hand went up first, so it's Margaret.
Thanks, Ruth. Yeah, totally agree with what you've just said, and I think for me it really demonstrates the culture in the organisation that we do encourage colleagues to look at ways to be more efficient and effective and really put the patients at the centre, so that was great. It also reminded me of obviously one of the metrics that were not that brilliant at, and that was around waiting times for rheumatology patients, because that's coming back to one of the meetings in September. Chris, you were going to do a bit of work around that, so it's just two-pronged. Firstly, great, really good to hear the initiatives, but also that does need to come back, and we do need to understand around waiting times and the outliers, so thank you.
Steve?
Just building on the previous points, trying to build that culture of innovation and not getting in the way of people having good ideas. So I just wonder whether or not there's merit in kind of trying to capture this in some kind of case study which could be shared in the next staff holiday, or some way of just getting it out there, because I think sometimes people don't see things as being possible unless they see it being possible elsewhere, and then they can bridge it across into their area and they've got their world or wherever they are.
Yeah, absolutely, that's right, isn't it, Mary?
I think we are very good at our ambition and about trying things and taking a major risk. I think we're also getting much better at stopping something if it's not working. Yeah. And that's not saying that anybody's failed, it's about learning from it and then trying it maybe a different way or doing it in another angle. It's good.
It's always the comment, isn't it? Entrepreneurs are good at failing because they give it a go and try something different. So I think it is really important that we acknowledge that. It's not a fail. You did something, it didn't work, you do something different. Absolutely. Okay, Joe, it's on to you again. We are on to the strategic priorities for carers, is that right?
It's the second patient.
Oh, patient staff experience. Sorry, I knew I'd missed something. See, I knew myself I missed it.
So just, I'll just do headlines from the report. So the patient and staff experience report, our headlines are in terms of the right time, so that's our external measurement, where we measure the experience of patients 2 weeks post-discharge, because we know that's the time where people are most likely to be dissatisfied if they are. We see strong performance, so the majority of our inpatient day case and patients report their care as excellent overall. Our outpatients, we do see that we've fallen below the mean for a number of data points, but I think we have to look at the scale, so it's still up in the very high 90s, so we're still performing well, but for ourselves we're dropping just below our mean, so that's something for us just to keep an eye on. I think picking up on Chris's presentation today is our emergency department experience. So if we look at the right time measurement for our emergency department in NSEC, we have fallen under the top 20% for a number of data points each month consecutively. If we look at the key areas that relates to, in particular, it is waiting, pain control, side effects of medication, and then that then contributes to the overall score. We also look at our ED patient experience in real time, so that gives our staff in the department a very quick way of understanding the patient experience within the department. So patients are called and interviewed over the telephone around 36 to 48 hours after an episode of care in ED, and that gives our staff some really timely and actionable data that that's given to them twice a month. And that reflects similar areas for improvement, which is the waiting and the pain control in particular, and around involvement. I will say, however, the first of July report has shown some marked improvement, which is absolutely great for patients, but absolutely going back to what we were saying about our staff. Hopefully some morale booster for staff at this challenging time. There's lots of work being done to address this, so we've talked about the front door model, but also I know the team have a quality improvement project around pain management within the department, and my team are helping with that in terms of the experience of patients with that pain management. If we look at our real-time inpatient measurement programme, we've seen some statistical improvement both in June and May relating to medicine management, cleanliness and involvement. And then we're piloting an AI platform at the moment, so just to highlight where we benchmark ourselves nationally against the public domain data, so this is where patients leave reviews, so it's patients talking about the things that matter most to them on Facebook, Google, NHS websites. We have a strong performance, so it's out of 5, so our score was 4.2. Regionally, it was 3.8, and nationally it was 3.6. So I think that demonstrates when patients are driven to talk about the things that matter about them in the public domain, the trust is holding a strong position when we benchmark ourselves. So in terms of staff experience, we're in the middle of the staff experience at the moment, and we're just around 3,000 responses to date. So we're looking at our numbers. Normally we've probably got, hopefully we'll get another third again of that, hopefully better. And we're monitoring those results. We had our first World Cafe on the 20th of June, and we had around 30 to 40 people. I think we did pick the wrong night because we chose the first night for England's game. So I think that was probably affected somewhat, but we did keep everyone up to date with the scores, which is appreciated.
Got my new place
So we got some amazing feedback on the night. We did a whole host of topics around flexible working, around women's health. And if the board could just allow me, I'd love to read this comment of somebody in sent us. I really love the concept of the World Cafe. What stimulating conversations, great ideas, insightful, thought-provoking, and a coming together of like-minded people who want the best for this organisation, its staff, and ultimately its patients. And I just thought that was an amazing piece of feedback. And we said to the group there, shall we do this again? And everyone said, yeah, do it again for other staff in other areas. So that's driven us to the next stage that we intend to do. So I thought that just would give everyone a bit of insight into some extra work we're doing at the moment.
Comments, questions? Alison.
Really good report. I guess my question is about the pain, particularly through the front door of NSEC. Somebody who's in acute pain, somebody got abdominal pain or got a fracture, there is an excuse we need to manage their pain. there are, and having worked there are a number of patients who come with long-term pain, that they come into ED looking for a cure that shouldn't and isn't practical to be delivered within ED. And I've been and done that and said to patients, you're going to have to go elsewhere. This is an ED department, it's not the place that can sort long-term pain. So they're going to score very poorly on that because I've not improved their pain. But that's not what the service is meant to do, and I think ED do feel that they should be doing the acute pain, but shouldn't be sorting out people's chronic pain. And my question is, how do we delineate that? Because there's a danger that we actually measure both together, and there are some where it's quite appropriate that within the confines of a 4-hour target and within the confines of what is an accident or an emergency for a patient, we shouldn't be sorting out their long-term pain issues.
And I think that's the challenge for our measurement, isn't it? That it's a mix of people which that people will be feeling.
And is there a way of asking how long have you had the pain? Because clearly if somebody's had the pain for a day or less, we need to be meeting it. If somebody who's had the pain long term, I just think it might allow a more nuanced report, because I need to know that we are dealing appropriately with the acute pain.
I think also within the real time, yeah, because it's an interview, so it's very plausible to be able to do that. So yeah, I think that's something we could have a chat with the team about and look at how we could use that.
Issues got.
Yeah, I guess there's something as well. So we know for the purpose of this, because we've been running the real-time survey for a number of months now, the scores originally were really low in terms of pain management. So we knew that it wasn't just a lot. So you're right in terms of that. In the future, delineation of getting what is long-term pain versus that immediacy. But I think the scores were very reflective of it. It was just something that we needed to improve on. You're right, we'll probably never be hitting 10s, but you know, we can be consistently hitting that 8 or 9 and then understand what that gap is.
It also gives no wriggle room for those who feel it's chronic pain and therefore the reason we're not meeting it is because it's in the other category. If we can say that that's only 5%, and the 85% of the acute pain you're not addressing, it's much more powerful in terms of the vehicle for change.
Mary?
I just wanted to draw people's attention to the score for the cleanliness of the wards and apartments in ED particularly, because if you can see there it's 9.96, and then we see the volume that's gone through, particularly for June. It was acknowledged at SQNI on Friday about this, and we've written from SQNI to facilities via DMAN to thank the teams for doing this, because although this is all work in progress with everything else there to improve those scores, we thought that was one that's definitely worth mentioning.
Absolutely, it is very good. Jeremy?
So, similar to Alistair's point on the unrealistic expectations, I think, and perhaps it isn't possible within a comprehensive survey to do what you need to do with acute pain. But maybe we need to do a targeted piece of work, because I do think there is something about we can be expected to see people in a timely way and help with their pain, but actually getting rid of it completely is another matter of time. So we need to understand what we're measuring and how we're responding to pain. Because I think that's all part and parcel of pain management.
Yeah, I think for me, I read the national stuff saying we're outside the top 20, and then you know where we sit. We know where we sit in the national picture. So there's an expectation issue here, isn't there? Maybe we've got a bigger expectation of people. We think we don't take so long to be seen. Maybe if I'm in Manchester, I think it takes me 12 hours whenever I go. I have a different level of expectation. Because us sitting outside the top 20 top 20% doesn't sit with our national figures for me. So I did wonder about the expectation management generally, whether that's what we're picking out. Joe, can I just ask, is there a volume on the real-time measurement in the emergency? Because we didn't, everywhere else we had a volume of patients or percentage. I didn't think we had one on real-time.
Yeah, we interviewed 40 patients per 20 per report. So of course, Chinese second course training, and there's one report.
Okay, that's really good, and Mary's point is absolutely right. The cleanliness is great, and the food as well. Actually, for me, food is one we've always got in our eye line, haven't we? And it does seem to be looking more positive. Okay.
Just on the staff experience in the little cafe, so we've had a really good experience in the first one, but I just think we need to be cognizant of where we do them, who come, so we don't want the same people coming all the time and the same views, and maybe Joe targeted it in places where we are struggling with some of the schools.
Yeah.
And so they can really targeted effort for the local cafes.
I totally agree, Kate. We just had our wash-up meeting yesterday for the cafe, and we talked about the next one being up north, going really up north before the winter sets in, and make it a community-based one as well, so that we can try and we want people to feel that there's sessions that for them. We've talked about, so this is a big PDSA cycle for us. We want to test time of day, location, organisational subset specific, all of these things, yeah, in this space year.
And I think as well, I know we've talked about this, World Cafes are excellent and clearly great feedback from the staff. There's still also, I think, some work that we should do alongside that, which is around being able to dig deeper into some of the questions that we put out in this real-time staff experience, so that we understand the thinking behind some of the responses, and we don't, we've always talked about the famous tools of the trade conversation, so that we understand what people mean by them. And I think we probably should try and get something in August before we sort of start to hit the winter about some of the questions that we might need to dig deeper into.
And I know that's a sort of one more thing, comment really on that, but just to include in the PDSA cycle going around, just around the grade mix that goes to those, and it's just something I picked up on my travels a little bit about, a little bit of a sense of that, it's all about listening to people that have been part of those conversations. So there's something about what mix of people go there, and then there's maybe something about, for the people who do go, whatever grade they are, what are they passing on afterwards, and actually sort of explicitly think about how they're going to tell their colleagues about it afterwards.
Yeah. Again, we talked about that, Andrew, as well, is understanding the grades, the roles, the locations of where people are coming from, in terms of who registers, who actually comes, who then, what do we learn, and then the evaluation, who's evaluating with us and what are they saying according to grade and location. So, or each time we're going to do this, we're going to learn more and more and just keep developing it as we go.
I just think it's great that we'll go back to face-to-face engagement as well. So that was a strategy for us for this year through Joe's work as well. And what we'll learn will be great through that face-to-face interaction.
Somebody came up to me at the end and said, actually, that was their main point, was having a chance to sit face-to-face and chat.
Brilliant. Thanks for that, Jo. You again on priorities for carers.
Thank you, Ruth. So I suppose I would link this one to what Margaret said just earlier around the so what, particularly when we're thinking about the patient staff stories. So you both will recall, I think it was probably 2 or 3 stories back, I brought a patient staff story that was related to carers and the carer experience on the ward. And Paul asked me to come back at a later date to talk about what we're doing in terms of carers within the organisation. So I won't say this was as a direct result, but this work was underway. So now what we're bringing to you today is the carer priorities that we've developed within the organisation for approval. So by way of background, it's just thinking about the sort of the facts and figures. So if we look at the census survey in 2021, they estimated there was around 5 million unpaid carers in England. But actually, Carers UK research in 2022 estimated it to be high as nearly just under 11 million people. And when we look in terms of the population across England and Wales, just under 5% are providing 20 hours or more of care a week, which is the amount of care and support they're giving to the populations of those countries is phenomenal, what that would cost. And why should we involve carers within the services that we deliver? I think if it wasn't morally just the right thing to do, there's lots of reasons. So there's mandatory and statutory requirements. So in particular, if we look at the Health and Social Care Act, there is a requirement for us to be able to involve carers in the discharge process. There's also the Act in terms of the Carers Leave Act that came into force in April of this year around support for our staff who are carers and the leave that they have as part of their caring role. But most importantly, I think, is that the role that carers have, the knowledge, the expertise, the love and compassion for the people that they care for, it makes them expert care partners in that care process and are an asset and a partner to us in terms of the care that we deliver to the people that are important for them and who they care for. So what we've been doing over the last 12 months is we've come together as a small group of people in Northumbria that all have an interest or a direct link with the experience of carers within the organisation. And what we've looked at is how can we develop a set of priorities that will act as a framework for everything that we do in relation to the experience of carers in the organisation. And what we've done is we've engaged right from the get-go. We wanted to involve people and co-design these priorities. So we utilised a number of ways. We worked with our staff through trust committees, such as Clinical Policy Group. We engaged with Ross's team through the BCS Work Cafe, which was amazing because there was 50 organisations there who are experts and advocates for the people that they care for and support within the community. We presented to our nursing and midwifery and allied professional board, but we also went externally to our key stakeholders, such as both carer partnership boards for both Northumberland and North Tyneside. And we asked for everyone's views and ideas, as well as pop-ups during Carers' Rights Day and Young Carers Day, to engage with patients and staff. So these are what we've come up with in terms of the engagement that we've done, and also looking at some of the best of the best in terms of what other organisations have done. So they've been truly shaped by what we know is working well, and through our own staff, our communities and key stakeholders. So it's very much developing a carer approach to ensure health inclusion, so going back to Patrick's presentation, reducing health inequalities, and importantly promoting health and well-being of our carers themselves and the people that they care for. We want to raise recognition and awareness of carers, because one of the things that we know is many people, if you're a wife or a husband caring for your lifelong partner, you don't see yourself as a carer because it's the person you're married to, the person that you love. A son, a daughter would feel exactly the same. So we want to raise awareness, and we also want to demonstrate how we value the knowledge of the carers and as expert partners in the care for the people they support. We want to improve in communication both with our carers and our staff by ensuring that we provide relevant and accessible information, but also that our staff have access to information to be able to signpost and support carers in their day-to-day business. And also increase the support that we give carers through coordinated care, shared decision making and the reasonable adjustments that we make. And I think the final one for me is what underpins all of this work is the collaborative relationships that we build with our key stakeholders, whether they be from the third sector or health and social care providers such as primary care, for example. So those are our priorities. In terms of next step, we have received sign-off from Safety, Quality and Improvement, so we bring them to board today for approval. We started to work with Health Watch, we're commissioning them to look at some key areas of experience for carers in terms of informing some of our actions. So discharge is one area that we will look at. We've also tasked them with working with carers, who we know come from some of our more vulnerable communities, who because of health inequalities will have a poorer experience because of those, to understand what will support them better. We have an opportunity to work with, be involved in the Working with Carers project, which is support that is offered could be offered to the Trust to support our staff who have a caring role within the organisation, so we're going to explore that further. And we are holding a big room event in October of this year. We know we do loads of great things in Northumbria to support carers, but we know we can do more. So what we thought this big room event would be is to map out what we do really well, and actually where are the gaps when we look at these priorities, so what are some of our key actions, and we will then develop a set of actions that we will take forward from there.
Excellent, thanks for that. Comments or questions, Richard? Oh, Margaret, sorry, I couldn't see you.
I just think this is absolutely fantastic. Well done, Jo. I really think this says so much about the organisation, and it's absolutely the right thing to do, but I think it really adds other benefits for us to be an employer of choice. It demonstrates our values, our behaviours. I thought it's a great paper. Love the idea of the big event, so just big thank you to you and your team for doing this work. Really important to co-create together, so excellent, absolutely excellent.
Thank you, Margaret. And if I could, I'd like to take the opportunity to thank Elena and Faye and my team, because they have put so much hard work into this piece of work. It's something they felt really strongly about, so I just wanted to publicly acknowledge that today.
That's excellent. And I think, just coming back to picking up on surveys, is this something where we can be clear that in that patient experience we are asking the views about, do you have a carer, were they engaged? Because that's where we can then follow it through in those numbers, can't we?
Absolutely, Ruth, and I think I will have clear action from that day, which is how do we understand the experience of our carers in terms of our measurement programme, so that's one of my actions, yeah.
Excellent. Thank you very much, that's really positive. Good. Right, we've got board walkabouts. We're a bit behind time, so speedy board walkabout. Steve, go. You're on.
Well, I have to be quick. I'll not read it. I'll just do it from memory. It was a great walkabout once met with Jeremy, escorting me around the premises, and a couple of things really. It was Volunteers Day, so as chair of the Charity Strategic Committee, I felt it incumbent to go and have a coffee before the walkabout and speak to the volunteers, and they were doing a great job. The cafe was very well used, and they were very busy. I have to say, they've been important, and it's getting busy. So that was a great start. Walking around the building, I was really struck, actually, probably more so than I've been in others. I've not found problems in other places that I've done walkabouts, but really struck by the cleanliness of Wandsworth. I was pleased that that's been replicated in other places, and at the Safety and Quality Committee on Friday we've agreed to write out to all the domestics to thank them for their endeavours in that regard.
Excellent.
What else? There's a great outdoor space there, which was beautifully kept and really kind of creates a relaxing, welcoming environment. But there is a little, I think it's like a kind of a Japanese themed garden, and part of the relationship we have with Teardrop, which is a kind of a fundraising initiative that is about people remembering loved ones. And for whatever reason, that just looked very unloved and cared for. It's quite small, you could easily walk past it and miss it, but it was a perfectly serviceable door opening. And I just wanted to hopefully find a way to check out what's that about. Why is some of the garden space well looked after and some of it not? And I don't know at all, but I'm aware that the part of the hospital at least has some PFI. And I don't know if there's some kind of issues around why that might be the case, that one bit of garden looks a little bit less looked after than others. Other things to report, we went into a couple of very busy areas. There was an elderly ward where we had a good chance to speak with a range of staff and patients, and the elderly ladies took me to task on a number of things, which was all in some ways very important, serious, but actually some of it was a lot of fun as well. They were really clearly capable and felt empowered to speak to me about the things that they wanted to speak about. And I thought it was just a really nice, engaging visit. One thing I think is worth pointing out, given that we've already had a presentation today, whenever I do walkabouts, I do ask for freedom to speak up question to staff. I must have spoken to around about 5 people in total and asked them directly. And there's a double-edged sword here. There's two things. One is, all of them said, we have a great culture here with freedom to speak on any matters that worry us. We're not, hindered in any way or barred from speaking out. But they didn't actually know the term freedom to speak up in the sort of clear way that maybe has been, I've heard anyway in other sites. So just something there for us to think about in terms of that freedom to speak up. And some 9 times out of 10 it seems to be very well done, but there may be just some topics where it's not as well. That's all.
Thanks for that, Steve. On the tier of garden, I don't think it is within the PFI, is it? No, I don't think it is. Hang on, Ross has got his hand in.
I don't think it is. Just on the gardens, I can provide a bit of an answer on that, in that I think maybe historically we would be a lot better at setting up the garden and getting it done than thinking about the long-term maintenance and the contractual elements and that. The charity teams do a piece of work at the minute to look at all the various contracts in place, and they're going to engage with our team here, but also with some of the external people and other external charities who have an interest in kind of sensory gardens and getting involved from a community perspective. So that bit of work's now done, so we're nearly there with that, and that's sort of heads up because we are aware of it, particularly the ones about sites.
Yeah.
A lot of the charity funded ones are really working.
Excellent. Mary?
Can I just say that I think that really is important for the teardrop garden, because I know certainly in others, as well as myself, when we're on call, if the patient's really upset, it's a lovely place to take them, particularly at night. It just absolutely calms them down. And because it's enclosed, you don't get the wind at you and everything else. It is really quite nice.
Completely agree. I think we are quite close to having that.
Thank you. That's actually important. And I think the other thing is just for Steve is I did hear the story when I was around the ward about the food spa. So, and they were very, very keen. They were very appreciative of you and Jeremy going round.
Andrew.
And I was just going to raise the freedom to speak up point that Steve started out on, because I thought it was quite interesting. We've said as a group of non-execs we'll ask that question a bit more on our travels, and Katie's obviously asked it further down and then has had some recognition there. So I think we knew this was patchy, and we've had various conversations around when does freedom to speak up get talked about, is it in induction, is it whatever. I think I'm just wondering if there's something a bit more explicit we do in the review to just look at awareness and where those gaps are, because it's quite interesting that we do ask some of those questions, I think, through sort of self-experience, or we kind of, or by implication we ask them, so we know some of the gaps, but I think there's probably something to learn from the conversations we have. Alistair and I'm not doing any spoilers because we'll present it next time. Alistair and I had a really interesting walk about yesterday. It was a long conversation about speaking up in general and freedom to speak up, and I think there's quite a lot to just still get under the skin of that.
Yes.
Yeah, thank you. So I was going to thank you. So it's really helpful for us from an intelligence perspective that you are asking these questions, and we know to then where we need to actively promote the service. One thing I would say is part of the review is looking at Freedom to Speak Up champions, and I think we probably haven't been the best at utilising that role within different areas. So I think hopefully that might help into some of these areas. And I think your point about the review looking at some of these areas where they don't understand it would be really helpful, and then we can get in.
That and balance issues. I think the comment that Steve indicated of, they said they didn't know about it, but actually in the same breath saying, but we've got no problem telling you when something's wrong. And I think that is absolutely a culture that we want to instill in people, that actually just don't wait. If there's something you're not happy about, you just need to say it. And there's always people around who will listen and act.
Jeremy?
So, just conscious of time, Chair, I'll try to wreck your first. So, two things. There was an absolute, because it is something that we do worry about, but there was a lady who spoke a Slavic language was there with a translator. The system working absolutely perfectly. That was really, really good to see, because that's not always the press that our translation services get. And secondly, just to link it to the Alliance agenda, there was a physiologist there who we recruited from abroad. We're in this fantastic building, but there is a real need within the region for us to work better, to develop the scientific community of physiologists to support our cardiac diagnostics, and we've got some really good stuff that we're doing that I think we just need to get on with.
Noted. So you feel
It's on the
Right, you've failed miserably, Steve, in my debrief, so
Well done, Steve.
Alistair and I continued our tour of theatres in the North East. Still haven't seen a musical, but have now seen a robot. So we went to North Tyneside because we'd previously been to Wansbeck, and it was good to see the comparisons and the differences because they are physically very different. What was really positive was seeing that they had their own culture. They were very different in the way they operated, while still having the same throughput and the same things. And North Tyneside is a very different fabric of a building, isn't it? It's a proper rabbit warren, isn't it, when you go around? I didn't put in my report for a bit of a miss, so I always ask about culture. I don't specifically always ask about freedom of speech, but we ask about culture, and specifically in theatres, being conscious of cultural issues. And again, everyone was very open, they felt very capable of saying anything that they felt uncomfortable about. That was really positive for me. It was good to see the robot, wasn't it, Alistair? It was good to go in and see it working, but it was also really good to hear the staff talking about how they practice for if it doesn't go well. If something happens to that robot, how do we respond to that live situation? And that was a real positive for me, to see that the fact that they were testing themselves frequently, because that's, you know, the worst case scenario. Other than that, really good, and the staff were coping really well with the fact that they didn't have the best access to facilities, because we know there's been a leak in North Tyneside, and they're in a temporary changing space, but they were all really positive about that because they knew that it was coming. They knew something was coming that was better, so that was really good feedback. And they do make amazing buffets. I think it's absolutely fair to say. I really wished I could have stayed. Katie, we've got you on Hawk Whistle and the safeguarding.
Yeah, thank you. So a big thank you to Marion for putting up with me all day for all the rest. I think what was really, well, a lot was excellent at Hawk Whistle, but what was really great was the actions that we found that day, that evening. Marion was already working on those actions, so it was great to see the purpose and the outlook of all that. So just a few points really. The facilities in every room were absolutely excellent, and that's coming through the patient experience today for Hawk Whistle. So clean, just great facilities throughout. The kitchen, I've never seen a kitchen quite like that kitchen. It's just absolutely amazing. What was also key was just the care that all staff were giving to the patients, real dignity and respect, and that was clearly coming through in everything that they were doing, and how well they knew the patients as well, even those just popping in, they knew the names, and it was lovely. It really came across what a part of the community Hawk Whistle is, which was lovely to see. Great family feel there, so some people are now doing roles that their parents have done, some have been there 40 years, and some have just started but already felt part of the family. So and a really strong multidisciplinary team, so providing the support that patients need. What was quite good, or was good actually, is to see there were some gaps in the beds, and therefore the pathway to care was really working. And I think also what is a concern is it was quite upsetting to see gentlemen who didn't want to move out of Hawk Whistle because the home he was going to was a long way from where he ever lived, and it just really pushed home the need for us. I think it's a brilliant model, and for us to expand this, I think there's just so many reasons why we should. I think the only concerns that came out of it, it was great that two overseas students now moved there, but they were a little concerned about the accommodation and the suitable accommodation that had been provided, which I know Marion was following up on that. A need to increase the physiotherapist's time there to make sure the patients get the support they need, and also same for the nutritionists. I think the main concern really was the hooligans who are jumping onto the scaffolding there, and staff seemed happy and safe, but I just think us thinking through getting appropriate lighting in place at Hawk Whistle, particularly for the moment.
It's all in hand, so we can increase it.
Shall I move to safeguarding then? So when I eventually found my way around here, got to see the safeguarding team, it was lovely to see them, a real strong mix. They were clear that the volume of safeguarding issues being raised is increasing, and just the number, the percentage of people is increasing as well. A great mix of their skills and experience, which they were really comfortable that they would understand all safeguarding concerns raised, which was great. All the colleagues echoed how well the team is working as one now, which is lovely to see, and the support that they're giving each other. So they won't allow these concerns to be managed individually, they'll always make sure they're released as well. A lot of extensive experience and time walking around GP practices and wards, and they're really an exemplar now for the training and the courses they do. So my only concern was that the team, and this may be what they want, the team were in the porter cabin at NSEC, so it's whether it's doing justice for the brilliant work that they're doing across the trust, whether we need to think through if that's the right location for them. But yeah, it was a really great time with them. They're very keen to expose themselves more to the board, and I think they should be. It's really just great to see.
Thank you. That's all really positive. I think the good message coming out is, for me, we see things and we raise things, and immediately I feel personally like you're on it, the exec are on it, we get that feedback really quickly, and that's really positive, so thanks to everybody for that. Okay, CQC Regulation 17, Ross.
Yeah, pleased to see that we're complying. This is the usual report that we're seeing around. Lots of good work going on, as you can see there. I think just want to say that it's an ongoing process, but myself and Joe's team are working much more closely on some of these issues because they are kind of aligned, otherwise it's separate kind of functional departments. We already mentioned a few of the things around staff engagement, around public engagement. As well as the sort of being compliant here, the bigger measure I suppose is being hinted earlier about the public perception survey, which while isn't exactly what we want, it does show a lot of clear water in terms of the national context and gives a lot of insight into how people feel, and a big part of that survey as well as how they're engaged with and communicating with, which all came out very strongly. Again, Jules stole a lot of my thunder on this, but one of the things you'll see there is that return to face-to-face events, which I've been talking about for quite a while when I present this, and we had some really positive ones in this time frame. So again, the GP excellence conference goes from strength to strength. The last one, again, loads of energy, really positive. Then we did hold our second event with the voluntary sector in the academy this week, and again, we've had fabulous feedback about that. We've already got loads of really good intelligence about how we're improving there. So hopefully really positive report, and we are compliant.
Excellent, thanks for that, Ross. So we've got the item strength escalation, which I'm going to take as read, unless anybody has any points to pick up on any of them. So we've got Marius Nursing and Midwifery report, the Allied Health Professional Staffing report, Corporate Safety and Quality report, and the financial report. They've all been through all the committees, obviously. So I think we are up to speed on those.
Could I just say two quick things?
Yes, of course, Mary.
And it's really for our benefit, because I know she's a great supporter of us, particularly with the EHP side of things. Because it's obviously work in progress, but we have seen that although the increase in vacancies for speech and language podiatry and ODPs have gone up, physio, dietetics and radiographers has actually gone down. So that's one point there, and we're also just keen to highlight any risks like that we have. The other digits I'd like to highlight is from the general side, and particularly NSEC, is about the rise in eating disorders that we've had. And the team are all onto it, but we wanted to highlight it. Jeremy's been pivotal in writing both a letter that's gone out to ICB about what provision is in the area. That these people need specialist care. Our teams have been great with them, but they are not trained in the area.
I did note that and did have that because it is a very
from CNTW, but we need to work and see what a forward plan is, because this won't go away. And the final thing is opening a report about corridor care to the next board meeting. That's something that we said that we would bring, and Elaine Prosperini, one of our heads of nursing, is doing that work with Marcus and the GT team, so they can get reassurance, as you mentioned earlier. We don't want this but we have to be realistic that it happens and it should be the exception, not the rule.
Absolutely. Thank you for that. Yeah, the eating disorders point is very important, isn't it? It is a very specialist area.
And it's not exactly this.
Yeah. Okay. Agenda for the next meeting. I'll find it. There we are. Just to note, so did you say, Marion, we were having something on corridor care next week?
Yeah, I'll go to the rest of the report. Yeah, right.
Okay. So a quick review of the meeting, things we've picked up. So generally good performance, but we know we're still never where we want to be, but we're good and we're performing well nationally. It's good to see the ICB are in support of where we are on the Alliance and that things are starting to move, particularly that health inequality work's really interesting, isn't it? And the collaboration. Chris gave us a good position on assurance in that patient quality and pressurised services, but I think we all acknowledge we're managing very high expectations and this reduced risk approach, and it is a challenging environment as we have more and more people turning up every day. Freedom to speak up. Good to hear about the interim arrangements and the review model will come back to us in September, and it's good to see we're getting out there, but in the walkabouts there's always more we can do. Equity and inclusion is a brilliant report, really understandable. I think everyone's really supportive of the way we're going, and good to see about the new staff groups. Patient and staff stories, I think the main message is have a go. If it doesn't work, we try something else, but it's good to see the staff being innovative and having a go. Patient experience, I think Alistair's point is really, really pertinent about let's look at what pain we can be expected to manage and what solutions we're being asked to give that are perhaps realistic in the circumstances in ED. And the World Cafe event's really positive, isn't it, to see that we're getting kind of back face to face with people, and it really does make a difference. The carers point, I didn't actually formally say, but we were asked to approve it, and I think generally the support was very clearly there, so I'm taking it that we have approved the position on the carers report. And then on the walkabouts, as I say, really good to see people getting out and about. But for me, the most positive thing is we bring those points back and they are actioned and people are picking up on them really quickly, so that's great. Really good to see. So I think that pretty much brings us to the end of the board meeting, except I've got one other lovely job to do, which is somebody here has been in the NHS for a really, really long time, Marion. And so we thought it would be absolutely right that we acknowledge in this public way your absolute commitment to the trust and your longevity of service. So Marion's been in the NHS for 50 years, thank you, which is amazing. A day over 25. So Marion and I rudely went around and asked your colleagues if they would give me a word to describe you, and they all said they couldn't use one word, but I've managed to get a few. I liked the fact that you were going to be stealing somebody else's thunder. I thought you should be the mother of the trust. But the honourable member for Berwick was mentioned. But generally, what everybody did was they all went, oh, you're empathetic, you're enthusiastic, you're brilliant, you're inspiring, you're kind, you're unique, and that is the case. You're superwoman, and then very personally, you were described as my matron. And Thelma by somebody else. But we are absolutely in awe of your amazing energy. None of us can believe how you keep going at the rate you keep going and the things you turn out. And the fact that everybody, whenever you go anywhere with Marion on a walkabout, she knows everybody, and everybody knows you. Although Chris did say when he first met you, he just said, this lovely Scottish lady keeps being really nice to me. I don't know who she is. She's been really nice to me. So I think it's a real testament to your energy and your commitment to the trust, and we are in awe. Congratulations.
Yes, thank you. Thank you very much. I mean, this is lovely. I mean, I am very lucky that I work for a fantastic trust, a fantastic CEO and board of directors and NEDs, and it's a privilege to come to work, seriously. Misha and I were talking about this yesterday, and it's not like coming to work because we do enjoy it, and I just love it. And I do say thank you very much. The stars are absolutely delightful. And we'll have tidal place in our living room this evening. Thank you.
Thank you. And then with that, we will close the meeting. Thank you very much.